Great. So I'm Thinmai Parasu. I'm a second-year medical student here at UTMB. And I'm also joined with Michelle Trang, who's a second year at UTMB as well. And so we have wonderful speakers today for our critical care section. First, we're going to have Dr. Desai. Dr. Desai is a vascular interventional radiologist and critical care ICU physician. He's from Brigham and Women's Hospital and the Harvard Medical School. He completed his training first at medical school at the University of Cincinnati College of Medicine, and then further went on to do his residency for radiology at Brigham and Women's Hospital, his VIR residency at University of Virginia Health Systems, and then his fellowship at critical care medicine in Brigham and Women's Hospital. His clinical focus is DVT, hypertension, peripheral and visceral aneurysms, PAD, PE, trauma imaging, varicose veins, and venous insufficiency. We're also joined by Dr. Vedantam, who is a vascular and interventional radiologist. He's a professor of radiology and surgery, assistant dean in clinical research, and medical director and Center for Clinical Studies at the Washington University of Mallinckrodt Institute for Radiology. He completed his training for medical school at the University of Chicago Pritzker School of Medicine, his residency in diagnostic radiology at UCLA, his fellowship in VIR at Stanford University, and his clinical focus lies in venous disease, including deep vein thrombosis, post-thrombotic syndrome, varicose veins, thrombolysis, mechanical thrombectomy, and stents. Last but not least, we're also joined with Dr. Butt. Dr. Butt is an associate program director of vascular and interventional radiology. He also is working out of Kaiser Permanente Los Angeles Medical Center. He completed his training for medical school at Ohio State University College of Medicine and completed his residency in diagnostic radiology at Los Angeles County and University of Southern California Medical Center. He also completed his fellowship in VIR at Miami Cardiac and Vascular Institute in the University of South Florida, and his clinical focus includes critical limb ischemia. So I'm going to stop here. I'm going to have Dr. Desai go ahead and share the screen.
Thanks a lot for that wonderful intro, and really excited to be a part of this for a few years running now. Want to shout out Dr. V for kind of spearheading this initiative to really get clinical IR out there. Hopefully everyone can see my screen. Today I'm going to be talking about the role of critical care in IR. Obviously, in 15 minutes, I can't teach or even go over all of critical care, but I'm going to try to impart to everyone why it's so important in our field. I don't have any disclosures. You may see this guy and hear about this guy a lot today, but this is Charles Dotter, the founder of IR. And this is one of his most famous quotes. He said in 1968, basically, if IRs are unwilling or unable to accept or secure for their patients clinical responsibilities, they will become high-priced plumbers. And other specialties will basically learn how to do the procedures and take the procedures themselves. And that was really prescient because that's exactly what happened for a lot of stuff, namely coronary angiography, but also PAD. But IR has also evolved since 1968. So if you look at modern IR practice, it involves many different aspects. It's got inpatient, outpatient consultation to develop a diagnostic and therapeutic plans, planning and performing image-guided surgery, of course, but also non-procedural management of peri-procedural inpatient emergencies, and then longitudinal care. So the knowledge base has evolved to match this practice, and we need to know how to do a lot of things, not just interpret lab and imaging studies, but do physical exams, formulate differential diagnoses, deliver difficult news to patients. We need to know the natural course of disease and how to manage patients longitudinally. And then what I'm going to be talking about now is acute patient care, right? So things like metabolic and electrolyte homeostasis, pain and sedation management, stabilization of emergencies, and multi-system physiology. So really to keep up with the evolution of our specialty, the ABR made a big change in training, right? And even John Kaufman himself said the major driver of this change has been the importance of non-procedural patient care in IR. So this is what we want it to look like. This is old IR training, kind of the three pillars, but one was really de-emphasized, and we want to make it an equal pillar. We want to make patient care equal to imaging and procedures for our training. So what is patient care? Really, it's two branches. One is acute patient care, and the other is longitudinal disease management, kind of what we do on a clinic basis. And digging further into what is acute patient care, really, you can break it down into these four big buckets: metabolic and electrolyte homeostasis, pain and sedation management, stabilization of cardiorespiratory emergencies, and multi-system physiology. So why is this important to you? And these are just examples, right? If you perform lung biopsies and bronchial artery embolization, if you do moderate sedation, you will at some point in your career encounter acute respiratory failure. If you do PCNs, biliary drainages, you will have patients in septic shock. If you do PE and DVT thrombectomy, you'll see RV failure and cardiogenic shock. If you do deal with hemorrhage and trauma embolization, you'll see hemorrhagic shock. If you do interventions on just sick patients, ICU patients, you'll definitely see arrhythmias, you'll see AKI, you'll see electrolyte abnormalities, hypoglycemia. You'll have to deal with mechanical circulatory support devices. And then if you do hepatobiliary work like TIPS, you'll see acute liver failure. So these are examples of scenarios, that I've encountered some of these, but I'm sure everybody who's been practicing for long enough sees things like, an INR of 4.5 with active pelvic hemorrhage. It's not just the procedure that we need to worry about. We need to know how to deal with an INR of 4.5 and how to reverse that. Or acute severe hypertension that's refractory to IV labetalol and hydralazine. If you're doing an angiogram, you can't just leave that patient and close them up because your arteriotomy is going to burst if they've got a super high blood pressure. So you need to know how to deal with acute hypertension. I don't have time to go over all these scenarios, but if you group them together, this is kind of my own idea of what are the big topics that we need to know in patient care for the VIR. So sedation, analgesia, and anesthesia, evaluation and initial management of undifferentiated shock, point of care ultrasound for the decompensating patient, acute airway management. So, knowing how to do a bronchoscopy or when to intubate someone, and approach to acute respiratory failure, knowing what to do if someone goes into an arrhythmia, treatment of acute severe hypertension, damage control resuscitation for hemorrhage, and treatment of coagulopathy. So, reversal of anticoagulation falls within this. Sepsis, cardiogenic shock and RV failure, acute kidney injury, fluids, electrolytes, and acid base management, and then peri-procedural and inpatient glucose management. So this is, again, just one case that I myself had to deal with in the IR suite, but it's really emblematic and of what, the severity of illness we should be able to handle is. So this was a healthy 57-year-old with a history of left lower extremity DVT, then developed extensive post-thrombotic syndrome, and they presented for venous reconstruction. So I saw them in clinic and recommended this, and they walked into the procedure suite. They were again relatively healthy except for the post-thrombotic syndrome. So we had a good start to the case. We had a successful crossing of a long segment chronic venous occlusion in the iliac and femoral veins. We got through and through access from the jugular down to the posterior tibial vein. And then I typically do this, I did angiojet, so I did pharmacomechanical thrombolysis and gave the TPA. And then all of a sudden, the anesthesiologist just panics and starts yelling at me and says, "Hey, this patient's desaturating, and I'm having these elevated peak inspiratory pressures on my ventilator." And then all of a sudden they start getting bradycardic and hypotensive. And, at that point, the anesthesiologist is yelling he's about to code. And so it's kind of on you, right? As the interventionalist, as the responsible party, what are you supposed to do in this scenario? And what are the possibilities? So you need to have a framework in your mind of how to deal with these kind of things. And it begins with, okay, my patient is hypotensive. They're in shock. What are the different reasons that someone's in shock, right? So you break it down into the four big categories. Is it hypovolemic? Well, there's no big reason for them to be super hypovolemic all of a sudden. Hemorrhage, I don't think I ruptured anything here, and especially the iliac veins, not really a real consideration, although it should be on your list. Distributive shock, probably not septic shock. Infection doesn't develop that early in the veins. Cardiogenic shock, of course, a possibility anytime you're doing a procedure. And then obstructive shock, something like massive pulmonary embolism or pericardial tamponade. Anytime you're working in blood vessels, either of these are always a possibility, right? So you got to think about, what are my tenets of shock management if I think someone's in shock? And your big three are: you got to support your cardiac output emergently, you have to identify hemodynamic derangements, and you have to diagnose and fix the underlying etiology. And so you have to be thinking along these three lines of therapy and diagnosis anytime someone becomes hypotensive. And in this case, you're working with a DVT or chronic DVT. Your first thought always has to be, did I throw a big pulmonary embolism? And if I did that, am I causing acute right ventricular failure that's then leading to obstructive shock, cardiogenic shock, right? And this is the death spiral, the famous death spiral that I think one of our speakers is going to talk about soon, so I won't belabor that. But what is the medical management of RV failure? If you think your patient is in this, you need to do three things. You need to reduce your RV afterload, you need to optimize your RV preload, and you need to maintain your mean arterial pressure and your cardiac output. And I put a little swan here because you also need to be very familiar with hemodynamics, right? If you're treating these things, you need to know that you're actually treating these things. So you have to know your values like cardiac index, you have to know your mean pulmonary artery pressure, your CVP, what are normals, what are abnormals. And so I won't, again, go into too much detail here, but reducing your afterload means you want to reduce your mean pulmonary arterial pressure. And so one of the big ways you can do this is, if the patient's intubated, you can give them inhaled pulmonary vasodilators, like epoprostenol or nitric acid. That dilates the pulmonary vasculature and reduces the afterload that the right ventricle has to pump against, and really reduces the work that it has to do. Optimizing RV preload means you don't want an overloaded right ventricle. If it's too full, it accelerates that RV death spiral. And so you want to keep an eye on your CVP, your central venous pressure, and diurese the patient as needed. Now, of course, this can be dangerous, right? Because if you empty your right ventricle too much, or dropping your preload too much, you end up on this side of the Frank-Starling curve, and you're going to go into cardiogenic shock. So this is a very tricky thing. And then maintain your MAP and your cardiac output. The fastest way to do that is to give pressors. And the best pressors to give in RV failure specifically are going to be things like epinephrine, vasopressin, things that particularly reduce your pulmonary vascular resistance while increasing your systemic vascular resistance, right? So they squeeze your peripheral vasculature, but they vasodilate your pulmonary vessels, so that your RV, again, is not overloaded by afterload, but it's seeing a lot more blood volume coming from the periphery. All right, so, I kept all that in mind. We started some epinephrine, we started some vasopressin, we intubated the patient and started some, or the patient was intubated, we started some inhaled Velitri. And then the next step, as you go back to interventionalist mode, right, which is cool that we can go back and forth between the two. And I say, all right, I need to look for a massive PE here. So this is my pulmonary angiogram, and I don't see anything that's big or central. So now you're really going back to the chalkboard, right? You're going back to the drawing board and saying, okay, I thought they had a massive PE leading to RV failure, but that's not what they have. And so now, what is their cause of shock? And at this point, you really got to think, is this cardiogenic shock, right? Because it's not RV afterload. And so you measure pulmonary pressures, and they're 60s over 40s, so they're pretty high. And so at this point, you really need to have echo skills. And as radiologists, it's kind of a shame that this isn't taught as just part of our normal residency, but an echo is not hard to do, and particularly a fast echo, meaning a bedside cardiac ultrasound, where you're just looking at very focused things. And so, again, I don't have time to go over, all the intricacies of this, but with Dr. V, who's kind of the managing editor for Techniques in VIR, I highly encourage you guys to check out this series of issues that we published. But one of them is how to do an ultrasound for IRs. And so these are all images that I created, but there's four views that every IR should know how to get. And that tells you very important information, right? So In this patient, this is actually what I saw, even though this isn't the actual picture, but this is the parasternal long axis view. You're looking at the left ventricle here, the left atrium here, and then the LVOT here. And what you can see is that the LV is not squeezing like it should, right? It's barely squeezing. Actually, it's pretty dilated. And so what that tells you is this patient's in LV failure. And that's really weird, right? Because the RV pressures are up and the LV is not beating. And so you have biventricular failure. And so now, you're putting all the puzzle pieces together, patient's hypotensive, and they're hypoxic, and now their heart as a whole is not beating well. And so what do you think of in terms of pathology? You think of this entity. It's called Takotsubo cardiomyopathy. It's stress cardiomyopathy. And it's basically where if a patient experiences some sort of acute stressful event, the LV just becomes shocked, right? And you go into cardiogenic shock, you become very, very sick. But the cool thing about this pathology is that it does get better. People get to the doorstep of death, basically, but if you can support them through it to the point where they don't code on your table, you can get them to the ICU. And this lady in particular was in the ICU for 2 to 3 days, got better, walked out. We got her to an allergy appointment because why did the Takotsubo happen? She was allergic to TPA. I've never seen this in my career, never heard about this, but she was allergic to TPA and went into anaphylactic shock. And the anesthesiologist, of course, rightfully so, slammed her with epinephrine. And probably that epinephrine is what stunned the myocardium and sent her into Takotsubo cardiomyopathy. So, very interesting case, and I'm really glad I had that critical care background to be able to recognize everything that was going on and just stabilize the patient. Nobody's asking you to, intubate or save the patient's life single-handedly, but just being able to recognize what's going on and stabilize the patient can save their life. So I'm not sure if I have some time left, but I'll go into kind of next steps and where I hope to see critical care going within the field of IR. So if you compare surgery to IR, right? I mean, in my mind, we're interventional surgeons. I just don't see a difference anymore from what we are to what the surgeons are. And if you look at our training, right, the surgeons have heavy weighting on critical care and on clinical care, on patient care. Whereas our training still, unfortunately, has very low emphasis on this. If you look at the surgical in-training exam, surgical critical care is 10% of that exam, right? And surgical/medical knowledge, things like fluids, electrolytes, acid base, nutrition and metabolism, transfusion is 20% of their exam. All right. Now, when you compare that to our study guide for VIR, this is a multi-page study guide, right? And interventions, imaging, and then you get 3 bullet points on patient care. And that's just not enough. That's something we need to do better with this as a specialty on. And so we need to expand this. The SIR has a critical care introductory course. We're doing a lot of things. I mentioned the TVIR issues that we're putting out, and hopefully, we're going to go to the APDIR and really advocate for a critical care curriculum that should be instituted nationally. And really, this is my hope, is to finally institute a critical care subspecialty certification. We have one for pain medicine. If you're an IR, you can actually get board certified in pain medicine. I just don't see why we can't do the same thing for critical care. And if you're interested in this as a trainee in becoming an IR and a critical care doctor, I really, advocate for yourselves to advocate with your program directors and directly with the ABR to say, look, we need this type of training program. We need this sort of pathway because in the end, we do patient care equally along with doing procedures and imaging, and this belongs in our specialty. So again, I want to say big thanks to the WCVIS, to Joji for really spearheading all of these efforts. And feel free to reach out to me here on Twitter or by email. These are just random pictures of a med flight rotation that I did during my critical care fellowship, which was a ton of fun. This is my wife, who's a DR, and our daughter, who was born in the same hospital we met in. So thank you guys all for your attention, and happy to answer any questions.
Thank you so much, Dr. Desai. Wonderful pictures. We really appreciate when we can get like such robust answers, especially when we're so early on in our training. I think we do have a couple questions in the chat, but I did have a question about you talked about expanding critical care. How do you kind of see it for medical students? How do you think that they should get involved early on in their training, especially if their school doesn't have such a robust program for critical care?
Yeah, most medical schools are associated with a hospital that has some sort of acuity, acute, hyperacute unit. So, for example, when I was a med student, I always had an interest in critical care, even though I knew I was going to do VIR. And every elective rotation chance I got, I just did a critical care rotation. And particularly, that includes, the cardiac ICU, where you'll learn pressors and mechanical circulatory support devices. It's the best place to learn hemodynamics. The surgical ICU is great for things like hemorrhage. And then the medical ICU is great for infection, right? And those are the three big things that an IR should know. And so I really, recommend finding those units if you can, and just spending some elective time there. That's all it really takes.
Awesome. And how do you suggest that trainees also develop the scripts that are needed to navigate difficult and niche cases such as what you saw?
You mean, just to clarify, do you mean kind of in terms of like the skills, the
Yeah.
critical care skills to navigate those type of acute scenarios?
Exactly.
Yeah, it's tough, and it's a very tough question because we as a specialty have done a very poor job of giving you guys that knowledge base, right? And so, number one, I would say use internal medicine resources or surgical resources. So, for example, the ICU book is a great starting place. It's literally called the ICU book. It's a great starting place, and that's what all the internal medicine residents use. And so, start there. Another amazing website is the Internet Book of Critical Care. I know it sounds kind of hokey, but if you just Google that, it's a fantastic, very practical resource where they tell you, not just the pathways for managing things, but also dosages of medications and all that kind of stuff. So I would just say to start with those two resources. The third one would be the ventilator book. That's a great one too. Start there and then advocate with your program directors to say, look, as a specialty, we need more training in this kind of stuff, and put pressure on us, people like us, to really create a curriculum.
Wonderful. Does anybody have any other questions? Great. Okay, so we're going to go ahead and switch over to Dr. Vedantam. Thank you so much, Dr. Desai.
Thank you.
Hi, everybody. Pleasure to be here this afternoon with you. I'm going to just get ready to share my slides here. Okay, and sorry. Okay, can you, that should hopefully work, and you can, hopefully it's a full screen for you. Well, so it's a pleasure to be here. Really enjoyed the last talk as well, Dr. Desai, really terrific. To talk to you today about pulmonary embolism, obviously very exciting for IRs right now, in particular, getting involved with, treating a very, a disease that's very central and that there's a lot of awareness of. And so these kinds of things have the potential to kind of elevate the profile of our specialty. Again, as was mentioned earlier, I developed an interest in venous disease pretty early in my career and evolved, acute DVT and chronic DVT and post-thrombotic syndrome. And then now, along with my partners, have gotten involved in the care of pulmonary embolism. So again, it's a very exciting landscape right now, a great opportunity for interventional radiology. I think that, as you may be aware, for a number of years, different types of clot removal therapies have been utilized in the sickest patients with pulmonary embolism, whether that's systemic administration of fibrinolytic drugs, surgical thrombectomy, and then more recently, catheter-directed therapy. There have been 16 randomized trials that have evaluated systemic lysis over the years and that have been kind of summarized in different meta-analyses. And then more recently, the kind of endovascular era started probably around 15 years ago with kind of pulmonary embolism looked at once more as a kind of potential target for clot removal therapies. The first sort of data point that we have that's kind of quality data was that in 2014, there was a small pilot randomized trial that evaluated the use of ultrasound-assisted catheter-directed thrombolysis for patients with intermediate risk pulmonary embolism, and found it to offer more reduction in the 24-hour right ventricular parameters than anticoagulation alone. And this kind of sparked kind of increasing development in the area. And since then, there's been the development of this kind of PERT consortium. Many of you may be aware of this, but maybe not all. But pulmonary embolism is a disorder that, again, is very complex, clinically, benefits from multi-specialty expertise. And so back around 15 years ago at Mass General, the first kind of collaborative group came together in what they call a pulmonary embolism response team in their institution. And that whole model of collaborative care spread to many institutions to where there are now significantly more than 100 PERTs around the country in different institutions. And we now actually have 8 randomized trials ongoing evaluating different types of therapies for advanced pulmonary embolism. So there's a ton of energy in this particular space, lots of new devices getting developed and being evaluated. But I think with all of that energy, it's very important to kind of take a very back to basics approach to just thinking about pulmonary embolism and why we're engaged and what we're actually trying to achieve. And I think that when you start to talk about cases, in your own institutions, for example, it can get pretty confusing, actually. It's very easy to understand the notion of, okay, patient is dying and has a massive clot, and we want to remove the clot and unload the heart and improve and save their life. That's kind of easy to understand. But on the other hand, when you think about the different reasons that get called on, right, that people invoke to do procedures in pulmonary embolism, it's actually quite a kind of across the map, really. You'll hear people talk about reducing RV strain and improving the patient's breathing ability. You'll talk about the symptoms of a patient initially with their acute PE. Can we alleviate symptoms faster? You'll hear them talk about this post-PE syndrome. In other words, the idea that patients after a PE, even if they get treated appropriately with anticoagulation, which is the mainstay of therapy, that down the road, they may develop long-term disability, exercise intolerance, chronic dyspnea, and other symptoms that may limit their quality of life down the road. And then also you'll hear about kind of length of stay type considerations and trying to speed their discharge from the ICU, et cetera. When you put it all together, sometimes it's not quite as clear why in any individual patient we're jumping to go ahead and do these procedures. Now, stepping back kind of at some of the historical way in which pulmonary embolism has been approached, it was learned early on, I'm talking about 20, 30 years ago, that patients with pulmonary embolism can be grouped into 3 broad categories. There's patients with high risk pulmonary embolism, essentially massive PE that are hypotensive, really. So they're quite severely affected. And these patients have a very high risk of mortality. And in general, the use of more aggressive therapies, such as surgical embolectomy or systemic thrombolysis, became somewhat accepted pretty early for that group of patients. There's also patients that have very low risk pulmonary embolism. And these are people who, if you just anticoagulate them, they have a very low risk of immediate mortality, less than 1%, So generally speaking, for those people, anticoagulation is sufficient, and many of them are treated as outpatients now. And then you get this category called intermediate risk PE, where patients present and they have one or more of several signs of right ventricular strain. And that could be that their RV looks large on CT scan. It could be that they have echocardiographic signs of RV strain. It could be that they have elevated troponins that are or BNPs that are kind of signifying micro ischemia and microinfarction of the heart. And so you can get different signs they're not always aligned, unfortunately. You wish it was kind of always a uniform picture, but it actually isn't, you know? And it turns out that this is a very large category of patients, maybe 20 to 40% of patients that present with PE. So this is a large group of patients, really, in whom it's really not necessarily clear. They're clearly at higher risk than others, but how high is that risk, really, you know? They're not really as bad as the massive PE patients, for example, right? And that leads to a lot of variability in care, you know. And there have been a number of trials with systemic thrombolysis that have evaluated its use in this population. And what they have found is a tiny mortality benefit. In other words, you have to treat around 70 or 80 patients in order to see one patient whose life is saved. But on the other side of the equation, when you use this kind of thrombolytic therapy at a very high dose, you get a lot more bleeding, including intracranial bleeding, that largely offsets that benefit, right? So it's very hard to know with this patient population, what should we be doing, you know? And when you start to look at the kinds of different factors that may predict adverse short-term outcomes, and this is kind of an example from the European Society of Cardiology guidelines in 2019. You know, you find that the strength of correlation isn't as strong as you would like. So when it comes to patients who come in and they're hemodynamically unstable and they have obvious acute RV failure, that does predict mortality pretty confidently. But then again, you get lots of other potential signs, right? A lowish, borderline systemic blood pressures, tachycardia, tachypnea, hypoxia, a presentation with syncope. And then you get these kind of risk scoring systems as well, the PESI scoring systems. You get other findings from echo or CT that have a lot weaker correlations, you know. And so it really can be very challenging to sort through all of it, you know. There have been very few studies of catheter-directed therapies that have been done with a high level of quality and with appropriate control groups. And again, we've got kind of catheter-directed thrombolysis-based treatments. We have mechanical thrombectomy devices that can suck clot out. And aside from that first early trial until very recently, we didn't have any randomized data. Now, just this past fall, the first randomized data came out on thrombectomy. And this was the STORM PE trial that was really a small randomized trial focused on basically taking people with intermediate high risk PE and randomizing them to get thrombectomy with the Penumbra device, their 16 French device, and anticoagulation versus anticoagulation alone. And the primary outcome of that study was this kind of RV-LV ratio, really a sign that on the CT scan, the right ventricle is dilated, essentially. And what they found is that with the use of thrombectomy, that does reduce the RV-LV ratio faster and more in the first 48 hours compared to anticoagulation alone. There's some sense that at 30 days, the 6-minute walking distance, which is a way to assess patients' kind of general exercise tolerance, you could say, is improved at 30 days in the people that got thrombectomized, and there wasn't a difference in major adverse events. You know, all of those are kind of positive findings suggesting that maybe doing something is beneficial for patients. And I think that actually seeing some data from a randomized trial with a control group is very encouraging, because the previous studies were all mostly single-arm studies where it's hard to know whether, even if you see a patient improving, is that because you thrombectomize them, or is it because of their anticoagulation, their excellent ICU care, just time and natural healing? You don't really know, right? With a control group, you can draw some inferences about the actual treatment that you provided, right? So overall, this was kind of a positive sign suggesting that maybe something is happening with what we're doing. And now on the other side of it, the RV-LV ratio as measured on a CT scan, it's kind of a surrogate outcome. Okay, it's not as important as, for example, mortality or, you know, the risk of acute decompensation or other hard outcomes, you know, that are more clinically meaningful to a patient. The trial really wasn't powered to evaluate those outcomes well. There was one fatal safety event that occurred pretty much almost during the procedure, and it was categorized as being not related, but it's hard to believe that would have been a not related event. So there could be a kind of a drawback. And again, it was an industry funded trial. So in terms of the overall, like how clean was the data analysis, you don't always know, really. I'm not really trying to cast aspersions on this particular study, but it's not the same thing as a trial that didn't have any industry involvement, you know. The PE data environment's rapidly evolving. There are other larger trials that are ongoing. The HI-PEITHO trial is evaluating ultrasound-assisted thrombolysis. The Peerless 2 trial is evaluating thrombectomy with a different device, the Inari FlowTriever. And then the PTRACT trial I'll talk about is a trial that's sponsored by the NIH. There's no device manufacturer involvement. It's a large multi-center trial, and it's looking at a different set of outcomes. It's looking at patients' exercise tolerance at 3 months and their basically how well they're doing at 1 year in terms of the New York Heart Association overall kind of disability class. So these are much more clinically relevant outcomes. That trial is about 90% enrolled, and so hopefully by next year we'll have some answers. And again, it's looking at a whole series of secondary outcomes as well. Blood specimens have been drawn as well, so we'll hopefully be able to correlate blood biomarkers with physiological testing with the clinical outcomes and gain a lot more insight into the actual disease itself, and then also the impact of catheter-directed therapies. Now, stepping way back and just saying, okay, if I'm starting to care for these patients, right, how should I be thinking about how I approach what I'm doing? Well, the first thing I would say is that, remember, these are sick and complex patients, so you really need to be approaching patients as a team, right? You want a holistic approach with multiple collaborators. Depending on the size of your institution, you may or may not be able to have a PERT in the sense of having 8 different specialties involved. But at a minimum, you want to have, procedure-based specialties and medical-based specialties involved, right? So that there's kind of this kind of multidisciplinary approach to evaluating patients. And you want to be thinking not just about whether a procedure is needed, but there's lots of other care issues that impact a PE patient's outcome that are much more important to think about, right? So you're seeing the patient in the emergency department, right? Okay, does this patient, how are you going to get them into the right care setting as quickly as possible? Is this a patient that needs to be in the ICU right away? Or is this someone that can go to a regular medical floor? Or even is it a patient that could be treated as an outpatient, right? That needs to be determined right up front, right? You need to get anticoagulation initiated right away and decide on what's the right agent to use. Are you going to use heparin-based anticoagulant therapy, low molecular weight heparin, or unfractionated heparin? Or are you going to go to a DOAC or an oral medicine right up front, right? You want to determine if an advanced therapy is needed, like thrombectomy or catheter-directed thrombolysis. Should the patient get an IVC filter? In general, if they can be anticoagulated, usually they don't need a filter. But again, that may be a potential issue for some people that may have contraindications to anticoagulation. You need to decide, is ECMO going to be needed? Is the patient crashing? Are they at high risk of crashing? And so do you want to involve and get mechanical circulatory support involved? And if that's the case, you want to consult cardiothoracic surgery very early, right? If you're going to be doing a procedure, do you want to have anesthesia involved? And if so, what type of anesthesia is going to be most appropriate? And then finally, you want to also plan ultimately for follow-up care, right, in the clinic afterwards, right? So there's a lot to be thought of beyond just, am I doing a procedure or not? And we really want interventional radiologists to be part of the care team that's making all of these decisions. And, being part of a care team like this, it really does take an approach, a mentality that you're going to really be learning and trying to understand other people's views and concerns and learn from their expertise and be willing to evolve your own approach, right? It's not just about getting people together, but it's about also being amenable to that type of interaction. It's important to remember, most of all, the one thing that's been shown, 30 years worth of research, time and time again, randomized trials, other kinds of other studies, what predicts whether a PE patient is going to die or not? It's the amount of time it takes to get them fully therapeutic on anticoagulation. That correlates with mortality, okay? So it's crucially important not to let a PERT process delay anticoagulant therapy and to use it as a way to make sure the patient gets fully therapeutic as soon as possible. The realities of using unfractionated heparin, the traditional heparin infusions, are that even in centers that monitor it carefully, it often takes 24 to 48 hours to get a patient fully therapeutic, okay? Whereas if you give them a dose of low molecular weight heparin, within an hour, the vast majority of patients are going to be therapeutic, right? So it's very important to be thinking through these issues and making sure that, now again, there are some patients who low molecular weight heparin isn't appropriate for, okay? But these are the decisions that need to be made upfront, and they actually impact mortality. And it has nothing to do with the procedure, really, right? It's a fallacy to think that you need to use unfractionated heparin if you're going to be maybe doing a procedure. People have thought, well, unfractionated heparin is reversible more readily. You can give protamine and reverse it very quickly and completely. Low molecular weight heparin, you can give protamine and it only reverses about 60% of the effect. But really, the number of patients in whom you're going to save their life if they bleed by giving them protamine, it's a tiny percentage of patients, right? When you put that up against the percentage of patients who may just die from their PE if you don't get them anticoagulated right away quickly, it's really not really the right approach to say that, okay, well, I might do a procedure and therefore I'm going to put them on unfractionated heparin, really, You should really be thinking about getting them therapeutic as fast as possible, right? And you definitely shouldn't be delaying anticoagulation to get a PERT consultation or whatever. You want to use meticulous technique if you're doing a procedure. You want to monitor the catheter advancement very carefully. Again, we're talking about advancing very large sheaths into the heart. And so you need to make sure you have excellent guide wire purchase with the wire of some moderate, at least, stiffness. You want to really carefully monitor the advancement of the large sheath into the heart. Remember, you're going through chordae and papillary muscles. You want to be very careful. And if you encounter impediments, you need to take your time in trying to get past them rather than just kind of shoving the catheter through there. You want to remember that when you get further out with your guide wire, there's the potential to perforate pulmonary artery branches. You want to remember that if you do cause any type of any type of leak, you can quickly get pericardial tamponade. You want to be monitoring for that and be prepared to put in a pericardial catheter if needed. So you want to have a lot of attention. And again, you're holding the sheath. You've got to remember the heart is a mobile structure. And so there's a movement that's inherently happening on the inside. So if you hold that sheath too rigidly and there's movement on the inside, there's going to be relative movement of the sheath against the walls of that vessel that you're in, right? So you have to be very careful with what you're doing when you're doing these procedures. When you're using a thrombectomy device, again, if you're going past, beyond the right or left main PA, you need to exercise extreme care in how you're using those devices. And some devices are quite large and some of them are smaller, but you got to be very, very careful, right? And I think that at the beginning, getting comfortable with one system is probably helpful. And this is a situation where early on, you really do want to have collaborators helping you. And in some cases, we even have the industry reps available. You don't really want them dictating how care is delivered, but they do know their devices pretty well. And early on with these devices, it is helpful to have them available for questions. Finally, you want to become a credible PE care advocate. I like what was said in the previous talk about knowing the disease and its natural history, independent of intervention. It's very important for us to do the studies and be part of doing studies to advance care and learn which patients benefit from what we have to offer and which patients don't. To do that, we need to eliminate our own blind spots. And the biggest blind spot we have as interventionalists is that we only see the patients that we intervene on, right? So we have to find ways to follow PE patients longitudinally in clinic and be part of those clinics, even patients that we don't necessarily intervene on. So this is a big challenge for our field to figure out how to do this. And I think that collaborative clinics with the pulmonary medicine and cardiology physicians is going to be probably what we need. We want to be contributing to quality improvement initiatives in the hospital. That's how you kind of build your leadership credentials in the hospital system, contribute to supporting the VTE prevention mission, and then also engaging advocacy organizations as well. So I'll stop there and see if there's any questions up front.
Great. Thank you so much, Dr. Vedantam. It's such a pleasure to hear you speak. A question that was sent to me is, in patients with intermediate risk PE who have suspected or confirmed HIT, how do you alter your management algorithm, particularly regarding anticoagulation choice?
Yeah, very often in a patient like that, we would use bivalirudin. And bival is very well established, kind of, especially in the cardiology world, and some institutions even prefer it over heparin actually as for routine use, But bival also has a short half-life, which is advantageous, just about 20 to 30 minutes, So if you need to stop it or whatever it is, you can do that pretty easily. So bival is often the choice. There are some patients in whom argatroban can be used as well. in truth, how often do I end up finding myself have to do this? Twice a year. So I find myself again talking to the pharmacy again just to be sure I've got the dosing straight in my head and all that kind of thing, But again, the key thing is rely on a team. You've got pharmacists in your hospital, right? Use them. And for these situations where you're doing something you don't do very often, use them. But you shouldn't look at that hit as a reason not to offer the patient different treatments. There are workarounds.
What about in the world of mechanical thrombectomies or things like that? How would you modify your approach in those spaces as well?
Not usually. I mean, I think you have to be careful that, again, if someone has hip, for example, it's not just giving heparin as a treatment. It's also every other form of heparin administration, right? You can't give any at all, right? So you just have to be very mindful of what you're doing in flushing your catheters and this and that. And there has to be good communication in the room to make sure that nobody drops that stuff into your flush or whatever it is and all that, But, does it make things a little more challenging? Sometimes, yes, but I don't think it has to be a deal breaker all the time, Yeah.
Another question that was sent was, as someone who has helped shape this field, where do you think that PE intervention is currently overused, or where do you think it's still underused?
Yeah, I think that it's always going to be hard to do randomized trials with the sickest patients, people who have massive PE and are crashing. And there are studies that have been prospective, but they've had kind of propensity matched comparator cohorts. And they certainly seem to lean towards the idea that thrombectomizing patients is beneficial, and I'm pretty much convinced. Now, the caveats, though, are that care varies a lot in each institution, right? To be able to deliver care for a sick patient like that effectively, you need to have the ability to monitor patients who are critically ill in your environment, transport them rapidly, have access to the CT surgeons when you need them, have access to anesthesia when you need them. If you don't have those operating conditions, you may not be able to replicate what's reported in these studies, right? So I think a lot of care has to go into really analyzing your own environment for those patients, right? But I do think that for massive PE patients, this stuff probably works, When it comes to intermediate risk PE, I think there's a lot, there probably is a fair amount of overuse. Now, again, we are doing the studies to try and work out in whom it helps. So I think the jury is still out on exactly which intermediate risk patients this will benefit from this and which won't. I worry a bit about some specific situations. One, someone arrives in the emergency department, they're pretty stable, they're on a couple liters of oxygen, and they get a little tachycardia. And then people want to jump the gun. Okay, well, tachycardia, like heart rates go up and down. If you scare somebody and say boo from the corner, their heart rate goes up, it doesn't mean that the world is coming to an end, right? Similarly, there are people who have not been therapeutic on their anticoagulation for very long, and they're getting worse. But okay, they've been there 12 hours, you haven't gotten them therapeutic, and you want to do a thrombectomy. Well, how about trying to get them therapeutic on heparin first, right? So I think that there are people, and the other excuse I hear sometimes as well, he's doing fine and he's on room air or he's on 2 liters of oxygen, but when he gets up to go to the bathroom, he desaturates. Well, okay, I mean, in the first 48 hours after a PE, it's a PE, right? I mean, it does take some time to recover, right? And you can be a little bit patient because remember, overall with intermediate risk PE, the mortality rate, the in-hospital mortality rate is like 3%. Most of these patients are going to survive, right? So you don't necessarily need to jump the gun there, So I do think people just have to kind of keep those things in mind.
And then I know that you're part of so many trials, ATTRACT, C-TRACT, PE-TRACT. How do you evaluate which trials you hope to be a part of or you aim to be a part of and which ones you don't?
The key thing really with trials and success with trials is commitment, honestly. It's really, and not spreading yourself too thin. I mean, sometimes people want to be part of the program and they sign up for 6 trials enrolling a similar population. And well, you're not going to enroll many patients each one. And each trial does take work. the main thing is to approach trials as a learning opportunity, right? You are learning how to do these trials better. And in the first year of doing the ATTRACT trial, we weren't very good at it. By the 5th year, we were a lot better than we were in the first year, you know? And so you have to be willing to change the way you're approaching what's happening in your trial, right? Learn from the network, right? That's one opportunity. But then as you're doing it, learn and change, and then just be open up, just think about your own population, right? Your patient population. And remember that sometimes you're enrolling at a time point that's earlier than when an IR would normally get involved. So you want to randomize people to an IR treatment versus a non-IR treatment. Well, guess what? That occurs before the time someone gets referred to IR. So if you're going to be successful in that trial, you have to figure out how to insert yourself in their care much earlier, right? And how to talk in a balanced way to patients about the different treatment options, right? So you have to consider what type of trial you're enrolling to, and can I be successful, and do I have the collaborators that will help me be successful?
Great. So I also have 2 questions in the chat. I just want to go ahead and read them out.
Sure.
Within the context of PERT, is there an algorithmic approach to determine which patients receive a catheter-directed therapy, or is it a case-by-case multidisciplinary care team discussion to determine if catheter therapy is important?
Yeah, it's definitely a case-by-case thing, you know, I'll tell you. And there are kind of algorithms that are in some of the guideline documents that are out there, but they're very broad. And individualizing care is so important, you know, especially in this time period where we can't really say to someone with intermediate risk PE that we know we're going to help you, right? It's really often a choice as to whether or not you want to take a more aggressive approach, right? So there's the issues of the doctors coming to a certain kind of consensus around, you know, when we might intervene. But then there's also the issue of sharing that information with the patient and being open and transparent about what you know and what you don't, right? And getting their input also in whether or not they want to go ahead with something, you know. So it's still pretty case by case.
Do you think there is a space for, you know, research or more analysis in there, or do you think it's just based on the interventionalist?
I think in a couple of years, we're going to be in a much better position because we're going to have the results of 4 randomized trials, you know, that all ask different, related but different questions. When you put the results of these 4 trials together, I think we're going to be a lot more and then you take the secondary analyses that get done. We're going to have a lot more confidence about which patients benefit and which don't. There'll still be room for individualization of care, but I think that we're going to be in a much better place, you know, in a couple of years.
Great. And for one of our last questions, do you perform a pulmonary angiogram prior to intervene or go on and do the thrombectomy based on the CT? And then is the concern of overloading the patient with fluid or contrast by doing the angiogram real?
The concern is real, but that's if you're there are ways to mitigate that though. I mean, you know, in the past, if we were doing a pulmonary arteriogram, you're giving, you know, 20 for 4, you know, a very high injection rate of contrast, right? To really opacify the pulmonary system because it's a very fast moving, you know, system, right? But if in the setting of acute PE, you're going to go in there, you're going to measure pressures. And if the PA pressures are elevated, you're not going to do that power injection at the same rate. You'll use a lot lower rate. In addition, you're using non-ionic contrast routinely nowadays, whereas in the old days, people weren't. And that was also another factor that made things worse. So I do think you want to be careful if they've got elevated pulmonary pressures. We do an angiogram in most of the patients, but we don't necessarily do it with the same amount of contrast, you know. And it depends a lot on and you know, again, if you're looking at a bit of clot in the PAs and there's flow going through, that's one thing. If you're looking at a totally occluded trunk, you know, right or left, you have to be a bit more careful in those situations.
And last but not least, a question about, you know, your background and your training. How did you, you know, find IR and what made you interested in that initially? Of course, that's a robust question, but, you know, what kind of called you to this?
Yeah, so now I'm going to accidentally date myself, which is not just a great idea. But when I was in medical school, the first TIPSs started to be done, you know, and I became aware of that. And I was interested in surgery at the time. And when I became aware of that, I was like, geez, this is pretty cool stuff, you know. So that kind of got me interested in IR. So I kind of went into pretty much went into radiology training knowing that I was interested in IR right up front, pretty much. And then venous disease, boy, I wouldn't have expected that. I didn't expect that at all. And that came a few years really into my, after being a faculty member, I just, I just did new procedures in a few different areas. And this is one where some opportunities just kind of came along to me and I kind of ran with them. And I learned early on that we don't have all the data that we need. And our medical colleagues are very skeptical with what we're doing. And that led me down the pathway of trying to help be part of the solution in terms of getting evidence and things like that,
Absolutely incredible. It was such a pleasure to hear you talk. And we're going to go ahead and move on to our next speaker. Thank you so much, Dr. Vedant.
Thanks, everyone. Yeah.
So next we have Dr. Butt. I'm going to go ahead and let him share his screen, and I'm also going to spotlight. Great.
Awesome.
Thank you, Dr.
You guys
Butt.
able to see?
Yes.
Okay, perfect. So thank you for having me. I'm excited to give this talk. It's kind of a new and interesting thing that we've been doing at Sunset as of late. I'm going to start off a little bit on my soapbox because I'm going to talk about this really cutting edge sort of thing that we're doing. But before you get to something like this, I think that the spirit of interventional, as you heard Dr. Vedantam's talk, you heard some of the other talks, the MSK talks, where it's at the vanguard of IR, right? The spirit of our specialty is innovation. And I think you get to do stuff like this by offering your clinical and technical expertise, but your background in solving really tough clinical problems and potentially applying solutions you use in one area to another area. And if I can say, the time that it really matters is when somebody calls with a patient who has a problem, and it's a tough problem that nobody can solve. And then, you don't ever have to say yes to a procedure. You do have to say yes to a consult. And that's something we stress in our residency program. If somebody had ever, if I had picked up the phone and I had the attitude, well, I won't do something because I've never done it, that's going to limit you in practice. So it's something to keep in mind. So when we got called by our cardiothoracic surgery team about this patient, this young woman that I'm going to talk about, who had endocarditis, and can we do anything, right? Of course, at the time, I knew that we hadn't done something for that problem, but not that we couldn't do something. And so we were happy to see the patient, and we had a conversation. It sort of led us down this potentially new service line. We're now in our hospital system. If this problem comes up, we're going to get, I'm confident we're going to be the ones to get called. I don't have any disclosures, but this case I'm going to present was a 31-year-old woman, had a history of smoking and a history of IV drug abuse, and was admitted with bacteremia and septic shock. She had a lot of the expected complications, including AKI, respiratory failure, was intubated, empyema, placed a chest tube. And her workup revealed a very large mobile vegetation in her tricuspid valve. And of course, she was initiated on antibiotics as a standard of care. But her bacteremia persisted. She had MSSA bacteremia. As you may know, the typical treatment is antibiotics, IV antibiotics for 6 weeks. However, she kept clinically deteriorating. Her cultures wouldn't clear. And they had an echocardiogram that showed right-sided endocarditis, right? So what's the problem, that we were dealing with in her? Well, she had a large mobile tricuspid valve vegetation. She had recurrent septic emboli. And as you may imagine, patients on pressors, septic, bacteremic, are not great surgical candidates, right? You can't exactly replace or repair a patient's valve when they're actively bacteremic. Any instrumentation, one, they may not survive the surgery, but beyond that, any instrumentation or foreign bodies you place might get immediately seated, right? And you're back where you started. So there has to be a way to clear the infection before you do any of the actual repair. So this is her CT scan. Again, as is typical, she had severe, significant bilateral pulmonary septic emboli with infarcts, bilateral effusions, respiratory failure. And this is a really striking echocardiogram. This is her initial transthoracic echocardiogram. And you can see this. I mean, if you haven't looked at a lot of echocardiograms, and I know we've stressed the importance of being comfortable with the skill set, you can do this. This is TEE, but certainly you can do a TTE, and these vegetations are large enough to see. This is a beautiful view of the right atrium here. This is the tricuspid valve. That's the right ventricle. And you see this mobile large vegetation on a thin stalk. If you look at the color Doppler images here, what we're looking at is that these vegetations prevent the tricuspid valve from coapting. And so now we see severe tricuspid. Basically, this is like flailed tricuspid regurgitation. Her valve is present, but it basically doesn't work because this vegetation has eaten or destroyed it and is preventing the valve, whatever remains of it, from coapting. So these are just, sort of different views of the endocarditis. And so this is another sort of echocardiogram view. So how can we address this problem, right? At least how can we address it percutaneously? We know that, okay, open heart surgery is certainly an option, but it's not a great option. She's very sick. And we talked about the problems with placing a foreign body, right? So why is a tricuspid valve different? Well, one, it's venous access and it's right-sided anatomy, right? And if we do have emboli during device manipulation or wire manipulation, pulmonary emboli in general are going to be better tolerated than a stroke or another left-sided process, right? Where you have acute limb ischemia, acute mesenteric ischemia, acute renal failure, etc. She's otherwise, prior to this, a pretty healthy patient, right? She's young, without other significant medical issues prior to this hospitalization. So this allows us to consider percutaneous options. Now, we always need a large bore aspiration system, right? A 10 French or 12 French catheter isn't going to cut it. Some of the penumbra things that we use, or some of the aspiration devices we use in the periphery, isn't going to work. Now, historically, we've used angiovac. The challenge with angiovac is that it requires ECMO and a perfusionist and is quite resource intensive. AlphaVac is a newer device that I'll talk about that allows us to forego some of that. It's a large bore aspiration system. There are different catheters available, but it has some of them have steerable tips that allow us to direct a funnel to a source of clot and aspirate. And then it allows us to do so without having a cardiac perfusionist. So it's just less resource intensive. And then you need some kind of imaging guidance, right? You can't do this under fluoroscopy. Certainly can't do this blind. So the two options are going to be intracardiac echocardiography and transesophageal echocardiography, each with its pluses and minuses. So ICE, you guys may be familiar with, very common in interventional, particularly in the tip space. You wouldn't think twice about using it now to place the tips, and with just a slight repositioning of the catheter, you can get a really nice view of the right heart. Okay, and so what you typically do, at least we typically do, is get groin access. We'll put a 10 French, 45 sheath up, and then we'll put our ICE catheter through that in the right atrium. Allows us to look at things in real time. And for this sick patient, we use general anesthesia, but you can imagine that just like we've used tips for many other indications without having the need for general anesthesia. So just using ICE itself does not require general anesthesia. And so why use ICE instead of a TEE? Well, one, it gives you real-time imaging guidance, right? As the operator or the physician doing the operation, you get to control the imaging, which is really nice because little minute movements really change your quality of visualization, particularly as you're dynamically moving a catheter. Perhaps you want to find the catheter tip and follow it as you direct it to the clot or the vegetation. You want to be able to control that. You don't have to have a transesophageal echo or anesthesia support. And it's just, it's nice to do the things yourself. And so what are you going to do to use ICE in this space, right? So like I said, you're going to come in from the groin. You're going to evaluate your vegetation attachment sites. In this case, we had a pretty large vegetation with a very thin attachment to the tricuspid valve. You can imagine that it could potentially migrate pretty easily, right? You can, of course, use this for leads. And if you do something bad, you're going to know pretty quickly, right? One, you're going to have an arrhythmia. Potentially, you're going to develop an effusion and detect tamponade early. And like Dr. Vedantam said, for the pulmonary embolism space, you have to kind of be ready for a plan. You have to have a plan ready in case you perforate the ventricle, rupture a chordae, rupture or perforate an atrium, etc. Right? And so this is kind of how you start. Okay, you start with a quote unquote home view. You're going to put the ICE catheter in the mid-right atrium, and you're going to face it towards the tricuspid valve. Okay, and then this is a nice little schematic here of what you're looking at. This is the right atrium, tricuspid valve, and then part of the right ventricle. And as you rotate your ICE catheter, you'll get a nice view of the RVOT. but you should be able to replicate this view with ice. Next time, if you have the opportunity, when you guys are doing a TIPS with ice, when you're done with the TIPS or whatever else, just put your ice catheter up in the right atrium and see if you can replicate these images. It's a really nice opportunity to practice. And remember that the tricuspid valve is an anterior-ish structure, right? Intermedial structure. And so that's how you're going to flip the ice catheter. It just takes a little bit of practice, but you'll definitely get it if you try. This is the AlphaVac system. It's the details perhaps are a little bit beyond the scope of this talk, but it comes in different sizes. This is, and this is off their website. This is an 18 French catheter, but it goes up to 22 French catheter. We used a 22 for this particular procedure through a 26 French jugular sheath. So in this case, we had groin access for the ice catheter with one of my partners, and then we had neck access with one of my other partners. And then, like any interesting high-risk case, especially one that you haven't done, what you do is you study, you see the patient, you tell them all the things that could happen. In my opinion, it's very, very important to tell them, listen, this is the first time we've done this, but I think we can do this to help, right? And then you get your friends in your department to help you do the case. And that's how you approach a new sort of disease process and a new high-risk intervention that you might want to try. Of course, percutaneous debulking isn't definitive therapy. They're going to be on antibiotics, okay? The idea is just like any abscess or anything else, you want to get source control and then let antibiotics do the rest, okay? And so in this case, this was our index case, and we've done other cases since then. But this we did in the cardiovascular OR. The subsequent case that we did in interventional radiology, all under ice. The first time we did it, we said, well, let's use TEE as our baseline, and then we're going to try to do the intervention with ice, and we'll kind of check our work with the TEE and see how things go. We already talked about why not surgery. Okay. This patient is going to need at some point some sort of valve surgery, but that's going to be deferred until we clear the infection, until her respiratory status is better. And we're going to try to counsel her and take care of some of these psychosocial issues, right? She can't, even if we clear her infection now, we don't want her at risk for reusing IV drugs in fear of seeding the foreign valve. So this is kind of the setup, right? So this is the three of us, Dr. Lamb, Dr. Vaticancherry, and myself. Like I said, you get your friends, and if you're going to do something hard, you kind of hold each other accountable and make sure you're not going to do anything silly. Screen left here is the fluoroscopic image. You can see our big sheath through which we have our AlphaVac catheter, and then this is the TEE probe that allowed us to use your work or check our work. The challenge is you don't want to have both of these on at the same time because the ultrasound waves will interfere with each other and will make visualization pretty difficult, right? So to be a little bit mindful, use one at a time. Again, because this was our first time using the ice catheter for this application, we hadn't sorted out exactly how to save images. So this is real time, this is what we were dealing with. This is all under ice now, right? There's no echocardiogram or a TEE picture. And if you hear the audio, we're just talking to each other. Hey, how do we do? If you've heard Dr. Vaticancherry talk, you'll hear him talk in the background, right? They say, hey, rotate it this way, rotate it that way, be mindful. We're all communicating out loud in real time. And you can imagine the room is packed with the cardiothoracic surgery team. In case we do something bad, we have the chest prepped in case we need to throw in a pericardial drain. We have bilateral groin access, and literally we were prepared for any eventuality, right? In this 31-year-old, and you can get a sense of the a little bit of tension in the operating room, right, as we're doing this. It takes me back. I won't have to show you the entire video. But this is us, again, just orienting our ice catheter and orienting this big funnel as the AlphaVac. If you've ever gone to an arcade game with your kids and played Frogger, this is almost like that, where the vegetation peeks his head out and you have to time the aspiration of the catheter. And then this is our actual vegetation aspiration. right? And that's what it was. Now, in this particular aspiration attempt, you have to be a little bit ginger, right? You can't pull too hard. If the valve is intact, you will rupture the chordae and you can potentially avulse the tricuspid valve, right? This is an opportunity for you to make a big mistake. So just because you have the catheter, or just because you have the vegetation in your funnel, be really mindful. Use soft hands and good technique. Okay. So right now the vegetation is really just stuck inside the valve or inside the funnel, and we're being mindful. And so now we've debulked a big chunk of that vegetation. Okay. And really what we did was we did this a few more times to get what else we could out. Okay. This is our final here. Oh, excuse me. There. This is our final here. Okay. And this is what came out. We got real chunks. We sent this to the lab and it grew out MSSA. Okay. And this is our final TEE images. Okay. You can see the difference in the volume of the vegetation. There is still florid tricuspid regurgitation, which we knew, right? She had that beforehand. But there was no change in the degree or severity or the hemodynamics intraprocedurally. We did have cardiac anesthesia with us for this particular procedure. You do have to be ready for, like I said, the mechanical complications, including perforation, bleeding, tamponade, et cetera, but also the arrhythmic complications, right? You have to have amiodarone, epinephrine, all the drugs you might use to control a life-threatening arrhythmia. You have to have that ready. And so we had at least a good technical result. Right now, technical isn't enough. How did she do after? Right. So as you guys remember, this is what her CT scan looked like before. She's about a year out from this initial event. She still hasn't gotten a tricuspid valve, but this is what her lungs look like now. They've totally healed. She's on, room air. She has no functional limitations. She's back at work. Okay. And she's actually pending tricuspid valve replacement this summer. And they're sort of going through the process of working her up and making sure that she's safe to do that surgery. So take-home messages. ICE provides really, really good imaging of the tricuspid valve. Get practice when you do a TIPS. Just advance your catheter a few more centimeters. You're in the right atrium. Get the views you need. You can do this for not just tricuspid vegetations. You can imagine you can do this for clot in transit, right? You don't need a TEE for that, right? Percutaneous vegetation removal, of course, is an adjunctive treatment that we could potentially use to help a lot of patients, right? And it does preserve future surgical options. So that's all I have for now. Happy to answer any questions.
Great. Let me make sure. Thank you, Dr. Bhatt. It was just an amazing talk. I'm seeing if there's any questions in the chat. So from Tulsi, as VIRs, we're always learning about new disease processes and trying to own the disease. What advice do you have for entering a new disease space? And what steps do you take to master it or manage it, a disease you have never seen before?
Yeah. So I think, we talk about lifelong learning in medicine, right? That's true in any specialty. Within interventional, we're such a disruptive force, right? Now we're in the MSK space, right? We're working in the same space as orthopods and sports medicine and these guys that have been doing it for decades, right? I think that you come to a new disease from a space of humility and you study like you're an intern, right? You read, and you don't read from IR sources, right? Because we're new in this space. We don't have the skill set to immediately know everything, right? I'll use the MSK example. We send our residents to rotate with sports medicine because I want them to learn how to do a proper knee exam. I want them to learn what functional limitations mean for the patient's ultimate outcome and how PT and PRP injections and hyaluronic acid injections. We should, especially as learners, right? You guys are always going to be welcome in spaces that perhaps your attendings may not be, right? And so just be humble and be hungry and learn as much as you can, right? And then when you start, especially in a new space with a new procedure, strict process, strict policy of full disclosure, right? You always tell the patient, listen, this is the first time I've done it. Okay. I've done it in other areas. I've used ice in other areas. I do PE work all the time. Right. But this is going to be a new application for the technology, and you don't let another specialist speak for you. Right. You go talk to the patient, you develop a relationship, you see him before, you see him after, you see him long-term. Right. And I think that's how you learn, particularly in natural history. Somebody had mentioned, we don't always do a good job of seeing what happens to patients we don't intervene on. That's the power of clinic, the value of clinic, right? Like if you see a PE patient that's high risk submassive and you opt to not, or high or intermediate high risk PE, and you opt not to intervene on that patient, definitely see them in clinic. Definitely see them in clinic and see if you were right, see if you were wrong. I think that's how you learn.
Great, Pearls. Another question that was sent was, when you're consulted for right-sided vegetations, I know you talked a little bit about it, but what clinical or imaging features makes you say that this patient needs this percutaneous debulking versus just continued medical therapy alone?
Yeah, so it's in this particular instance, it wasn't rocket science, right? Anybody with endocarditis, their first line therapy is going to be IV antibiotics, right? Most patients will respond and do fine. Okay. In this particular patient, she had already been in the hospital for like a couple of weeks with persistent bacteremia, and the vegetation wasn't changing or responding to therapy. And that's what made the decision. It sort of pushed us to do something here. Now this is like I said, this is our index case. We had never done it, right? But when the call came in, we saw the consult. We talked amongst each other. We talked to the cardiac surgery team. We said, like, what if we didn't do anything? What would you do then? Right? Because we don't know the natural history of this disease. We are new in this space, right? Okay, if we do, like, what's the goal of our treatment? What are we trying to achieve? Surgeon says, well, listen, like, if you guys can clear the vegetation, we can clear the bacteremia, we can get her out of the hospital, she would ultimately get a valve replacement. Okay. So that's how you learn, right? Like, hey, tell me what would happen if we did something in your estimation. Tell me what happened if we didn't do anything. And now we have more experience than we did during this index case, right? So our judgment is a little bit better honed.
Great. And last but not least, what do you see as the timeline for this being the treatment, across the nation per se?
Well, I think, I think people already do it. It's described. I think this disease is, endocarditis is common, but refractory endocarditis perhaps is less common, right? And we're talking about a right-sided heart problem, right? We're not even talking about the aortic valve, mitral valve. This is all, and pulmonary artery or pulmonary valve endocarditis is super rare. So we're really just talking about tricuspid valve disease, right? And most of the time response to antibiotics. So, the AlphaVac in particular is much less resource intensive. I think this is a degree of like comfort. If you're comfortable with the disease, you're able to collaborate in the space and you understand your limitations. I think you could do it now, right? But I think the challenge is not so much like, okay, when can all IRs do this, right? It's like, well, as the interventionalist, if you get called, will you go see the patient and feel comfortable talking about this disease and how sick they are and their comorbidities, right? And so it ties into everything you've heard about this critical care in this critical care block with the ICU care, the initial case about PE, the subsequent talk about catheter-directed therapy for PEs. You could do it now. You could do it now. You just have to build, learn and build.
Great. Dr. Boxkin-Cherry is also agreeing with you in the chat. So just wonderful to hear from y'all's robust experience. I want to go ahead for the interest of time and kind of wrap up next week.